Hi, everyone. My name's Ashley. I'm the head of patient services at Winona. Thank you so much for coming to our March Winona patient Q&A. This is our chief medical officer, Dr. Green. He's going to be giving a little bit about himself, and then we'll get started with the question and answers.
So hi, my name's Mike Green. I am an OBGYN, an MD. I actually did a family practice residency first because when I was in medical school, I liked every rotation I was on. So when I was trying to decide what I want to be when I grow up, I'm like, well, I like a little bit of everything, so I should do family practice, kind of the buffet specialty. But when I got done with my family practice residency, I found out a couple of things about medicine. One is I really don't like taking care of sick people. It's really depressing. And the other is I love delivering babies. Everyone around me told me I had good surgical hands, and I really had a passion for women's health. So I did a whole second residency in OBGYN, and I'm board certified OBGYN, and that's pretty much what I've spent my 22 plus career doing. We've been doing Winona. We're coming up. We're almost at our 1 year launch date. Of course, we were working on it a lot longer than that before we actually launched. But so Winona has sort of kind of taken over my professional life over the last bit, and it's been really exciting. It's just a great way to be able to provide healthcare for people in a simple, easy way, but still keeping it safe and effective. And unfortunately, I can tell you in training, we never really got a whole lot of training on menopause management. It's mostly about surgery and delivering babies and stuff like that. And so it's not a skill that some of the OBGYNs have or do well. And so it's something that there's really the potential to do a lot of benefit because people have a hard time sometimes finding a doctor that is willing to do hormone replacement therapy and quite frankly is good at it. And so it's something that I spend a lot of time kind of learning all the latest, getting up to snuff, making sure we're doing it right, and doing the best, latest treatment that's available. So anyway, welcome. The purpose of this is education and to help answer questions that you might have. My kind of philosophy about healthcare is that the doctor's job primarily is really as an educator. It's not to tell you what to do or what not to do. It's to educate you about your choices. We all have choices about what we want to do, how we want to live our life. There's what medications we want to take, what we don't want to take. And so I feel like if I can educate you and really let you understand sort of what the options are, and then you can choose what's the right option for you. And my feeling is as long as it's safe, I'm happy to do an option that for you may be better, even if I don't understand why that may be the case. So my primary responsibility is to keep you safe. And so I won't prescribe something that I think is dangerous. But apart from that, there's a lot of styles of doing things. One of the things I want to talk about, because it came up last week, is sort of the difference between birth control pills and hormone replacement therapy. Because there's some bad medicine out there that's happening where people are just throwing birth control pills at people instead of hormone replacement therapy, mostly because as an OBGYN, we get a lot of experience with birth control pills and less experience with HRT. And so people are more comfortable using something that they have more experience with, even if it's not the best treatment. One of the things I do besides this is I train other doctors how to use Nexplanon, which is an implantable birth control device. And so I was at a training where I was training a group of OBGYNs, and I happened to have a conversation beforehand. I was sort of chit-chatting with the head of the group, this OBGYN, and talked a little bit about Winona. And he's like, oh, I just put everybody on birth control pills till they're 55 and don't worry about it. And, I didn't want to insult the guy, but I'm thinking to myself, that's a really bad way of doing it. And, honestly, I was thinking 10, 15 years ago, I was doing some of that. I mean, not as bad as this guy, but I was doing some of that as well. And so it really made me think about it. And my assumption is if he's doing that, a lot of people are doing it. And so a lot of you may be hearing that from your OBGYNs. So I want to talk real quick about the difference between birth control pills and HRT, when you would use one over the other, or when sometimes you would use both, because I think it'll be helpful. And then we'll get to your questions. By the way, go ahead and start putting your questions in the chat box if you aren't already. So we'll have questions to answer when I get done talking. So birth control pills there's lots of different kinds of birth control pills on the market and lots of formulations. But the sort of classic birth control pill is an estrogen and a progesterone taken together in a pill, usually, again, classically for 21 days. And then you get fake pills or placebo pills for 7 days. So that's sort of your classic birth control pill. And there's lots of variations on that because, quite honestly, every drug company wants to come up with a different pill that's unique so they can say theirs is the best and get some market share. But let's just sort of talk about the classic birth control pill. The estrogen that is typically used is ethinyl estradiol, which is a synthetic estrogen. The progesterone that's used is actually a progestin because that's what we call synthetic progesterones. And so it's always a synthetic progesterone. And this is what really varies in birth control pills because each drug company comes out with a sort of slightly different take on their synthetic progestin because they have different side effect profiles. And the problem is these progestins all have side effects. So the fact that there's so many different ones tells you something that there isn't sort of one best one. And then each drug company says, oh, ours is the best because it has the fewest side effect because of this special progestin that we use. Hormone replacement therapy, again, typically has an estrogen and a progesterone. But at least with Winona, we use bioidentical hormones. So they're true estrogens and progesterones. They're non-synthetic, bioidentical. And what bioidentical means is that they're chemically identical to what your body already makes. So when you take those in, your body can't tell the difference between the hormones in the hormone replacement therapy and the hormones that your body naturally makes. And that means that there aren't the same kind of side effects we get with these synthetic hormones that we find in birth control pills because they work exactly the same as your natural hormones. So there's a big advantage right there in that the way these work in your body, the hormone replacement therapy bioidenticals, is really the same as what your body is looking for. Whereas with synthetic hormones, they cover most of the stuff that the bioidenticals, but there's holes in that coverage because your body doesn't really recognize them as exactly the same. And so that causes side effects. And it also means that they don't work as well on all the symptoms. So birth control pills primarily are for birth control. So they are designed to prevent pregnancy as really their primary function. They have some secondary functions. They tend to make periods really regular and they tend to make periods lighter, which is kind of a nice side effect. And so the way the birth control pills are dosed is they're huge amounts of hormone compared to hormone replacement therapy. Because the idea is to give so much hormone that your brain says, whoa, I got plenty of hormone floating around, and tells your ovaries to stop producing hormone. And that completely shuts the ovary down. And so all of your hormones are now taken over by these synthetic hormones. Because your ovary is shut down, your ovaries aren't producing eggs, and that's why you don't get pregnant. And they work really well at that. So that's what they're designed for. They work well for that, and that's what they do. Hormone replacement therapy doesn't do that. It's a much lower dose. So it doesn't shut the ovary down. So the ovary continues to produce all the normal hormones that it's producing. The hormone replacement therapy comes alongside the ovary and sort of helps it out and supplements more hormone. Because the problem with perimenopause and menopause is that as we age, the ovaries produce less and less hormone as they sort of getting ready to shut down. That can be a 10-year or longer process. And so the whole point of hormone replacement therapy isn't to overwhelm the ovary, but to work alongside the ovary to get your hormone level back up to where it was like in your youthful normal state and get you feeling youthful again and back to where you were. So the problem with using birth control pills for hormone replacement therapy is, number one, you're using a huge dose of hormones that you don't really need. So that's going to increase your risk and your side effects just because of this giant dose. And number two, you're completely replacing the hormone that your body was making. The natural hormone you're replacing with a synthetic hormone that doesn't work as well as a natural hormone. The other thing is that because you're only giving estrogen and progesterone, but you're shutting the ovary down completely, you're losing the testosterone effect that the ovaries make because you've shut that down and you haven't replaced it. And so that's another problem that we see with birth control pills. With hormone replacement therapy, because you're not shutting the ovary down, you can use a whole lot less. Because it's bioidentical, you don't have the same side effect profile and you get better coverage. So it treats the symptoms more effectively than birth control pills. So if you need pregnancy prevention and you want to do it with pills, birth control pills are great. Honestly, you may be better off with something else like the Nexplanon or an IUD because they're more effective. But that's a perfectly acceptable thing to do. Or if you need the birth control pills for the because you have bad periods and they're fixing your period, that's a reasonable way to go as well. But for a lot of people, even though they're on birth control pills, they're still finding that they're having menopause symptoms because of these differences in the treatment. And in those cases, it makes sense to supplement then back with bioidentical hormones to cover those holes that the birth control pills are missing and get you feeling well again. So that's sort of the difference between birth control pills and HRT. It's why the sort of lazy approach is just throw birth control pills at everybody. There's a saying that if all you have is a hammer, the whole world looks like a nail. So if all you're comfortable with is birth control pills, that's what you're going to use, even if it's not the best choice. A more subtle and effective way to do it is with hormone replacement therapy, usually instead of birth control pills, but sometimes alongside the birth control pills, so you can get the benefits of both. So anyway, I hope that helps. I hope I didn't lose you, but that's the concept and the difference, even though because it's confusing because they're both estrogen and progesterone. So what's the difference? And there really is a lot of big difference between the two. So hopefully we have some questions we can get to.
Yeah.
To hear just what I think is important. Okay.
Angela asked, should I take progesterone every day?
So the short answer is yes, that's the easiest way to do it. The long answer is not necessarily. It depends on what your goals are. So the primary reason that we give progesterone is to protect the inside lining of the uterus. That's called the endometrium. So estrogen, the job of estrogen, outside of hormone replacement therapy, but really the primary job of estrogen is to tell the inside lining of the uterus, grow, 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 because there's an egg coming. The job of progesterone is then to organize that growth and get it nice and organized and ready for the egg when it comes. The problem with hormone replacement therapy, if you have a uterus and you give just estrogen, then all you're getting is grow, 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 and you're not getting any organization. The progesterone helps organize the lining while you're on the estrogen, and that keeps it safe, because if it's just grow, 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 grow with no organization, that's the kind of environment that a uterine cancer develops in. And so estrogen alone, if you have a uterus without progesterone, can lead to a uterine cancer. The interesting thing is that when estrogen and progesterone are used together, your risk of uterine cancer is actually lower than not taking any hormones at all. So it works really well at organizing the uterus and keeping the risk of cancer down. The easiest way to do it is just take both of them together and you don't have to worry about it. And I think that's a great strategy, and it's the way that I typically prescribe. But there are other ways that also work at preventing uterine cancer. One way is if you're taking oral progesterone, to take it every other day. That's effective. The problem is, it's, at least for me, it's a whole lot easier to take something every day than to take something every other day. And then you tend to forget, it's like, did I take it today or did I take it yesterday? And then you can go a few days and miss it, and then we're going to lead with problems. The other strategy that some people use is they give estrogen every day, and then they give progesterone only a certain amount of days, either every month or every couple of months, like 10 days or 14 days out of the month. And that works. It does work to prevent cancer. The problem is, it can cause bleeding. And so most women don't really want to have periods if they don't have to. And so one of the sort of bonuses for menopause is the periods go away. And it's kind of a bummer then if somebody comes with medicine and starts a period up again. And so for most people, that's not sort of the way that they want to do it. So those are all safe ways of doing it. The third thing or fourth thing or whatever number we're on, but the other thing is that progesterone has some benefits as well. Progesterone tends to increase mood. It's sort of the happy hormone. It also is sedating for most people. And so if you take it at night, it can really help with sleep. So taking it every day has benefits beyond just the protection of the uterus, but there's benefits to the progesterone itself. So no, you don't have to take it every day. I think it's the easiest way and probably most beneficial way to do it. But there are other strategies that are reasonable that work as well. So that answers that question.
All right, Sue had a question. How long does one have to stay on HRT for menopause relief?
That's a really good question. The problem is the have to, because you don't have to stay on HRT any length of time. It's really how long do women tend to want to stay on hormone replacement therapy. The average woman will be on hormone replacement therapy for about 5 years, but there's a huge range in that. And there are some women that decide that they want to be on it for the rest of their life. There are other women that may be only on it for a year or two to get them through sort of a bump in the road. There are certain symptoms that tend to get better as menopause progresses. Hot flashes and night sweats, they tend to get worse, they peak, and then as women go through menopause and kind of go out on the other side, they tend to get better. There are other symptoms that just continue to progressively get worse. The vaginal dryness, painful intercourse, thinning of the vaginal walls, some of the urinary problems, those all typically get worse over time. So for some women, that's a big problem, and they want to stay on the hormone replacement therapy for that reason. So my advice is, sort of depending on your age and where you are in your sort of menopause journey, is at some point, maybe 2-3 years into treatment, go a month without it and see how you feel. If you feel the same, probably don't need it anymore. If you're finding, oh my gosh, things are getting bad again, then we want to get you back on. And so I think it's a reasonable experiment to do. It's not dangerous, but you want to choose a time when, if symptoms come back, it's not like, going to be horrible. Like if you're planning a wedding, that's probably the wrong time to do it or something like that. But, when life is sort of, calm, maybe you've been on it for 2 or 3 years, it might be worth going off of it for a month or two and see how you feel. If you don't feel any different, you don't need it anymore. If you're finding that, oh my gosh, my symptoms are back, we put you back on it, and we try that experiment again in a year or 2 or 3 when you're willing to give it a shot again. But the average length of time is about 5 years.
Okay. Dawn asked, what are the benefits of progesterone if you do not have a uterus anymore?
So as I was talking about before, the primary reason we use progesterone is to protect the lining of the uterus. So if your uterus isn't there anymore, we don't have to protect it. If it's sitting in the pathologist's office in a jar, we don't have to worry about it. Kind of kidding about that, but there are benefits of progesterone, as I said before. So progesterone is sort of a happy hormone. It does help with mood, and it can help with people that are struggling with mood issues and stabilize the mood and sort of make them, make life a little bit more pleasant. It also can help with sleep. So if there are sleep issues, progesterone can help a lot with that, taken at night. So those are the sort of the big things. There's some subtle things as well, but those are the big things that people notice. My general recommendation is, if you don't have a uterus, I usually try with just estrogen alone. My personal feeling is the less medicine you need to be on, the better. But don't be afraid to take medicine if it makes your life better. But there's no reason to take medicine just to take medicine. So if you have symptoms that are really seem to me to be mostly coming from estrogen or testosterone and not as much from progesterone, I'd recommend, if you don't have a uterus, to try it without the progesterone and see how you do. If you find that it's really not meeting all your needs, then we can add progesterone and see if that sort of gets you over the hump. But might as well try to do it with the fewest medicines needed to get you where you need to be.
Okay. Sue asked, how is HRT treatment identical to what is already in the body? What evidence is there that it's identical?
So that's a good question. And technically, it's not identical to what's in the body. The bioidentical means that the hormones that we're using are identical to some of the hormones that the ovaries produce. So the body can't tell the difference between the hormones that the ovary are making and the hormones that are in the Winona products. They're the same chemically. If you isolated them and handed them to a chemist, they couldn't tell the difference. So they act the exact same way on the body. And so the evidence is that they're chemically identical. So estradiol is estradiol, and it's the same chemically, and therefore it's going to act the same on the body. We don't try to give identical amounts of hormone that your ovary ever made, because that would be more than you need. And so it depends on sort of your definition of identical. The hormones themselves are identical to the ones that the body makes, but we aren't necessarily giving this sort of exact identical amount, especially since the hormones that the ovary makes aren't constant over time. They're not even constant over the month. They go up and down. But that up and down can cause problems, especially once we get into the perimenopause period. So we give a steady dose to really, again, supplement what the ovary is making and kind of keep equilibrium going. So the hormones themselves are chemically identical. They therefore act on the body identically, but it's not really identical to the way the ovary makes them. because giving them in a steady amount and giving them in a lower amount is really what's needed to get people feeling better, which is really sort of the whole point of this. Hope that makes sense.
Okay. Eileen asked, I started Winona HRT 4 months ago. I'm feeling better, sleeping better, and have more energy, but the DHEA is causing major acne. What are your thoughts on keto 7 instead of DHEA? I recently started taking 2 DHEA and my acne has gotten worse. Should I cut back to 1 or should I take keto 7?
So I'll be honest with you, I have no experience with keto 7. I don't want to speak about keto 7 because it'll be out of ignorance. It's not something that I've prescribed before or really have experience with it. But I can tell you about the DHEA. The DHEA really is a testosterone boost. And honestly, some women don't need it. It can have some testosterone side effects, and that could be what's causing the acne. It definitely can help with libido and energy and weight loss. And so for that, it can be really useful. But some women, get that benefit and then we have to withdraw it for one reason or another, either because of acne or other problems, and they still do well. I can tell you, my wife, I started her on the cream and the DHEA, and she was doing well. And then the DHEA started giving her side effects. And so we took away the DHEA, and she's done well, and her weight loss has continued, and she's been really happy with the cream by itself. So the DHEA can be very helpful, and often it can really fill a gap that the estrogen and progesterone don't fill. But for some women, they don't really miss it when it's withdrawn, and if it's causing side effects, it's worth going off of it. The keto 7, honestly, I'm going to have to look up because it's not something that I've used or that I have any knowledge about. So I don't want to, I'm much happier to tell you I don't know than to make up a bunch of BS. So what comes out of my mouth is stuff that I'm pretty sure I'm right about, and I don't want to make something up. And so I don't really know anything about keto 7, so I don't want to speak about something I don't know about.
Okay. Keita Clinton, do you need progesterone if you've had an ablation and have no lining?
Yes. So an ablation, first of all, it doesn't completely take away the entire uterine lining. It takes away enough of it that for most people, they have little or no bleeding. Ablations are great for women that have bad periods and bad bleeding. But it's interesting. If you look at people that have had ablation, about 80% of them are satisfied with the outcome of their ablation, but only about a third of them have no bleeding, which means there's still some endometrium there, even though it's been ablated, because it doesn't actually wipe out the entire endometrial level. So you can still get an endometrial cancer after ablation. And honestly, that's one of the things. So I'm old enough to be around before we really had ablations. They had some things that we tried that didn't work well, but the modern ablations, they came out actually when I was in practice. And one of the concerns that we all had was, gee, are we going to miss uterine cancer? And I don't think that answer's been, I don't think that question's been completely answered yet. Ablation is a great thing. I do them, most of us do them, but there is that little question mark. And the thing with uterine cancer, the good news about uterine cancer is that we tend to find it really early, and so we can treat it when it's still treatable, and women tend to do well after a uterine cancer. But the reason that is because women have bleeding, and then people don't like bleeding, so they come to the doctor, and then the doctor says, better make sure this isn't from a pre-cancer or a cancer, and we figure it out either before it's a cancer or when it's really early. That's as opposed to, say, ovarian cancer, which has really no symptoms for most people until it's almost too late. And so ovarian cancers, women with ovarian cancers tend to have a much harder time and don't do as well as women with uterine cancers. And the reason is because uterine cancers present early because of the bleeding. That was one of the things that we were always a little worried about with ablations. Like, gee, are we going to be covering up this bleeding? And so women are going to have cancers. And we're going to turn uterine cancers into ovarian cancers as far as survival rate and how bad they are. And, we haven't seen that too badly, which fortunate, and it's probably because, I haven't seen data for this, but it's possible that because we are getting rid of a lot of that endometrium, we don't see as many uterine cancers after ablation. I don't know for sure whether that's true or not. I haven't seen data for it, but it does make some sense. But on the other hand, it doesn't mean you can't get an endometrial cancer because there's still some endometrial cells there. So it's really important to still be on progesterone with estrogen, because even though you don't have enough endometrium to cause bleeding problems, there's still cells there that can be stimulated and cause a problem. And that's, again, safety first. If I take away your hot flashes but give you cancer, I haven't done you any good. So that's something that, it's just, you don't want to mess with. And so, yes, I would not feel comfortable prescribing estrogen without progesterone in somebody that still has a uterus but had an ablation. And that's the reason for it. I'm very conservative when it comes to patient safety. Again, my primary responsibility is your health, and I take that seriously. So I really want to make you feel better. But if I have to say, I'm sorry, I can't make you feel better because it's too dangerous, I'll tell you that. I sometimes tease my pregnant patients that, number one, keep you healthy. Number two, keep your baby healthy. Number three, give you a good experience. But you know what? If I have to piss you off to keep you or your baby healthy, I'm going to do that. And sometimes it comes down to that. And it's the same thing here. Keeping you healthy is more important than anything else. So I wouldn't take that risk.
Okay. Very nicely put. Rachel asks, I'm 3 months into Winona. Sleep, hot flashes, and night sweats have been leveled out. I doubled the DHEA and night sweats and hot flashes have returned. Have reduced it back to 25 milligrams, but I'm still dealing with sleepiness in the middle of sleeplessness in the middle of the night and night sweats. Question, how do you find the sweet spot? Going back to the original dose has not brought me back to my good place. Purpose of increasing the DHEA was to promote weight loss.
So yeah, the problem is the sweet spot sometimes moves. We find that dose that's the sweet spot, and that may be the sweet spot for some amount of time, and then the sweet spot moves on you, and the dose is no longer enough, or maybe it's too much. And that's sort of the battle we have with medicine in general, is the body's not static and it changes. If you think about what's going on with the ovaries, as we're in perimenopause, that ovary is going to be making less and less hormone over time. And so the amount of hormone the ovary is making now may be here, and 6 months from now, it may be down to here. And so that means that the amount of hormone we need to replace to get it back up to where it's doing you benefit might increase over time. So one of the things that might be happening is that the contribution of hormone from the ovary is decreasing as it naturally does. And so in order to get you that benefit, we might need to increase the amount of hormones. So that's one thing that could be happening. I don't think increasing the DHEA would have caused night sweats, because the DHEA does increase the amount of estrogen you get, not by a whole lot, but by a little, because DHEA breaks down into both estrogen and testosterone. It's a testosterone benefit we're mostly going after with the DHEA, but increasing the DHEA should not decrease the estrogen and increase the night sweats. So I think that was sort of a coincidence in timing, but it may be that we need to increase the strength of the cream to get the night sweats under control. That's probably the way that we need to do, and most likely it has to do with the amount of hormone that's coming from the ovary maybe decreasing. The other thing that's frustrating is that it's not a nice, steady, linear decrease. It can spike up and down for no particular reason. So, your ovary may be making sort of a bunch of hormone today, and 2 weeks from now it's making a whole lot less, and 2 weeks from now it's making a different level. And so that's one of the frustrating things about this perimenopause, is that the ovary kind of spits and spurts in how much hormone it's making. It's not a nice, gentle decrease. If it was, there'd be a lot less problems. But it's the sort of spikes and drops that cause a lot of the problems. So it might be that you're sort of in the middle of a drop right now of the amount of hormone the ovary's making, and it may kind of kick back in and start making some more on its own, or we may need to supplement with more hormone in the cream.
Angela asked, thank you for answering my question about the progesterone. I don't have a uterus. My other question is, do you prescribe testosterone? Sorry. I currently use HRT with a pellet that lasts about 6 months. It is an estrogen and testosterone. I have a great response to testosterone, so I was asking because if I switch to Winona, I would like testosterone and estrogen.
So the short answer is no, we don't prescribe testosterone, and it's not because I don't believe in testosterone. I think testosterone is an important part of hormone replacement therapy because certainly the ovaries are making less and less testosterone over time, and that's a problem for people. So the problem is that with telehealth, well, there's an exception to this, but in general with telehealth, we can't prescribe controlled substances in the way that we do telehealth, and testosterone is a controlled substance. So there are emergency rules because of COVID, where people are sort of getting around that and providing testosterone anyway. We as a company have decided not to build our company around those emergency rules because we want this to be sustainable. The COVID rules are going to go away soon, so I don't want to sort of bait and switch you and give you testosterone this month and then next month say, oh, I can't do that anymore, sorry. And so, we want this to be a sustainable thing because we know that we're going to be taking care of women for years going forward. And we want to be able to do something that we can continue even though these COVID rules are going to go away. So because testosterone is a controlled substance, we can't do it with the type of telehealth that we do with Winona. However, we can use DHEA, and DHEA is another bioidentical hormone. The type of DHEA we use gets broken down into estrogen and testosterone within 30 minutes of ingestion. So this is where it gets confusing for people because it doesn't really affect the DHEA levels in your blood. That's sort of a separate thing. But what it does is it's sort of a sneaky way and a legal way of giving you testosterone replacement without using a controlled substance. So we give you DHEA, that gets broken down into estrogen and testosterone, and that increases your testosterone levels. For most women, a small amount of DHEA will get your testosterone back to sort of normal, low to low normal levels, which is usually what's necessary to give you the boost you need from the testosterone, but without the testosterone side effects. Now, some patients, like one of the ladies that asked a question earlier, you can get testosterone side effects from DHEA. Acne is one of them, but honestly, that's fairly unusual, and most people do really well with the amount of DHEA that I prescribe. The problem with DHEA, sort of if you go on the internet and start researching it, is that DHEA is used in competitive sports, particularly bodybuilding. And in fact, it's banned in a lot of these professional sports because of that reason. It's used in the bodybuilding community in very high doses to give very high levels of testosterone because that's what helps bodybuilders. And so there's a lot of sort of warnings out there about these, side effects from DHEA, but it's mostly at these massive doses that are used in the gym. And in the dosages that I use, really 25 to 50 milligrams, we don't get, for most people, those testosterone side effects, but we do get the benefits of testosterone. I have a lot of patients that have transferred over from pellets to using the Winona products, quite frankly, because it's so much more convenient. We have, mostly people, creams, but I'd say about 80% of our patients are using creams. That seems to be the most popular, but we also have pills and patches. But the idea is you don't have to go to the doctor's office. You don't have to go to the pharmacy. You don't have to get a painful procedure every 3 to 6 months. If you decide this isn't working for me or it's giving me side effects, you stop using it and it's gone. Whereas the pellets, you're sort of stuck with it until they wear off in 3 to 4 to 6 months. So I think that the creams and the pills and the patches, sort of more traditional ways that we give HRT, have a lot of benefit over the pellets. You don't have, this painful procedure. You can back out if you don't like it. It's a whole lot less expensive and it's a lot more convenient, and you still get the benefits. So we've had a lot of patients that were on pellets come over and they've been very happy. And that includes people that were on testosterone pellets, have been very happy with the estrogen creams and the DHEA, or pills or patches for that matter. It seems to do what the pellets do without the sort of downsides of the pellets.
We have another question about DHEA from Dawn. Off topic, but hoping you can help. My OBGYN gave me testosterone cream, but I do not want to use that because it's expensive and there can be side effects. If I take DHEA without adding testosterone, will that still help my libido and protect my bone health? Parentheses, no ovaries. I do not want my lady parts to shrivel up.
So the DHEA, as I said, does help, and it'll get your testosterone really to levels to normal levels. So unless you're looking to, compete in a bodybuilding tournament, you don't really need more than normal levels, and that should get your libido up. It helps with weight loss. As far as shriveling up lady parts, the estrogen is going to help more with that than the testosterone. But the DHEA does give some estrogen contribution, but for most women, not enough to get the estrogen that they need, and so we usually combine the DHEA with an estrogen and progesterone if needed. But the DHEA, like I said, for most women, even women that were coming off of testosterone therapy, either with creams or the pellets, have been very happy with the DHEA and are telling me that, yeah, they're still getting the same benefits, and usually without a lot of the side effects that the testosterone. The other thing is that because the DHEA in appropriate doses won't overshoot, it's not something that we need to follow testosterone levels with, because we know that we can safely do it and we're not going to kick the testosterone up way too high.
Perfect. Yassi asked, my Winona HR cream doesn't say how much estrogen and progesterone are in it. How do we find out what we're taking?
So it's confusing. It actually does, but it doesn't say it in real good English, quite honestly. So the estrogen is, the dose of the medicines are measured in milligrams per milliliter. The typical 2-pump dose that most women are on is a half of a milliliter or a half of a gram. So the dose will say, for instance, 3/150 or 5/200 or 1/100. That first number is the milligrams of estrogen. And in the cream, we use what's called a bias cream. It's a 50-50 mix of estradiol and estriol, because that, again, is more bioidentical, sort of more mimics what the ovaries normally make. So the first number is the milligrams of estrogen per ml, and the second number is the milligrams of progesterone per ml. Half that number, because you only use half an ml per day, and that's your daily dose. So if the thing says 5/200, that means every day you're getting 2.5 milligrams of estrogen and 150 milligrams. We said 200. 100 milligrams. I'm going to do the math, right? Of progesterone every day. So again, you'll have that number, and that tells you your daily dose if you're using 2 pumps a day. If that's still confusing, shoot me a message, or whichever doctor is taking care of you. We're happy to explain it and tell you exactly what your dose is.
Next question, Sue Burns. What are your thoughts on a low-dose HRT prior to a breast cancer diagnosis?
So, yeah, that's a tough one. So here's the thing. There is a slight increased risk of breast cancer with HRT. It's small, and in fact, in the Women's Health Initiative study, the women that were on just estrogen, they didn't even see it. So it's small, but probably there. The risk is tempered by the benefits of other things. So, for instance, if you're a appropriate candidate for hormone replacement therapy and you start it before 60, your risk of cardiovascular disease goes way down. You also have a decreased risk of colon cancer and endometrial cancer and other cancers. So overall, when you look at life expectancy, your life expectancy if you take HRT appropriately, is higher. In other words, you're more likely to live longer than if you never took the HRT at all. However, if you have a breast cancer diagnosis, there is this concern that the hormones could stimulate any little cells that are remaining of the breast cancer, and give you a recurrence of the breast cancer. There is data that women that are 5 years out of breast cancer diagnosis likely are safe to take HRT, but quite honestly, it's pretty scary, and it's not the kind of thing that I feel comfortable doing. If for no other reason, if you do get a recurrence of your breast cancer, even if it's not my fault, but I gave you hormones, I'm not going to feel good about that. You're not going to feel good about that. And that's not a good place to be. So that's one of the things that we don't do, is we do not give hormone replacement therapy for women with a personal history of breast cancer. If you feel strongly and that's something that you want, I would recommend talking to your oncologist. That's the person that's most likely going to be comfortable providing hormone replacement therapy if they think it's appropriate for your individual condition. They know the most about your breast cancer. They know the most about the risk in your individual situation. That's one of these sort of edge cases that really is going to take a sit-down conversation face-to-face with all of your history and data that we just can't do at Winona. And honestly, I wouldn't do it in my office. I'd send you to the oncologist. It's too scary. This may not sound great, but I got to sleep at night. And if I'm doing things that I'm worried is going to hurt somebody, I can't sleep at night. So that's sort of what's the right word for it? That's like a little test for me. Like if I'm going to prescribe this and it's like, gosh, I'm going to be up all night worrying about it, it's probably not a good thing to prescribe. Now, a family history of breast cancer is different, and that's often quite misunderstood. Family history of breast cancer, hormone replacement therapy has been shown to be fine. In several large studies, women even that have a very strong family history of breast cancer, it's safe to give them hormone replacement therapy. The caveat is if you have a genetic marker like BRCA for breast cancer, then that goes back into the personal history. And again, it's something that I wouldn't prescribe. But if your mom had breast cancer or your sister had breast cancer or Aunt Alice had breast cancer, it would be safe to take hormone replacement therapy.
Rachel had a really interesting question. Could the stress of the world contribute to the changes in ovary production, simultaneous world events, and changing dosage?
So stress contributes to a lot of problems. And I think, yes, people that are in high stress conditions or situations are going to be more likely to shut off basic needs. It's sort of a survival instinct. So if somebody's on the edge and all of a sudden they're in a high risk situation, I think it's very likely that their hormones are going to produce, their ovaries are going to produce less hormone. We actually know, if you look at sort of really competitive athletes, women that do sort of marathon runners or endurance sports, they tend not to menstruate because their brain shuts their ovaries down. And the kind of idea behind this is that when you're really stressing your body, either physically, like, in athletics, or emotionally, or whatever, but you're under a very high stress situation, there's a mechanism for your body that says, look, this is the wrong time to have kids. And so it sort of shuts down the mechanism to make kids, shuts the ovaries down. That decreases your hormone level and can certainly flare up sort of your HRT symptoms. Unfortunately, the last couple of years have been a nightmare for most of us, between COVID and the stress of, what's going on in Europe right now. And so, we all live under stressful times. Some people handle that stress differently, and some people, internalize it. Some people are able to sort of get through it. And there's sort of a personality thing about how we handle stress differently. But I think, yes, certainly very stressful conditions can definitely change the amount of hormones that your ovaries are producing. And, sort of all else being equal, might make it so now you're getting symptoms that you may not have had if you weren't stressed out. So yeah, I think that's a very real thing. It's a really interesting question. But from a physiologic point of view, it makes a lot of sense. I have not seen. I've seen studies. There's obviously lots of studies on sort of athletes, and that kind of stuff. But I haven't seen a lot of studies on just sort of socially stressed situations. But I would expect that would be the same.
Winona asks, don't we put adrenals into a dormant state by taking DHEA and estrogen?
No, because we're not providing so much hormone, again, that we're shutting down the hormone producing, whether that be the ovaries or the adrenals. We're not shutting down the hormone producing organs. So if you give enough hormone, yes, you can shut down the adrenals, you can shut down the ovaries. If you give too much thyroid, you can shut down thyroid replacement, you can shut down the thyroid. So if you overdo it, yes, you can affect those organs. But in the doses we use with hormone replacement therapy, no, that shouldn't be an issue. You start giving somebody massive quantities of HRT or massive quantities of DHEA, yeah, that's a real concern. But in the doses we use conventionally, doses that I prescribe, that shouldn't be a concern.
Can HRT cause weight gain? I've been on HRT prescribed as I'm going to mispronounce this along with other mispronunciations I've had tonight. A troche? Okay. I've put on 30 pounds in the last year since being on it. Or is weight gain more because of being in menopause?
So HRT really should not cause weight gain in the long run. Now, progesterone is kind of an interesting hormone. In really high doses, progesterone can stimulate appetite and cause weight gain because you eat too much. The classic example is Depo-Provera, which is a birth control shot that's this huge slug of progesterone. And anybody that does birth control, that prescribes birth control, knows there's a certain amount of people, you give them Depo and they come back in 3 months and they're 50 pounds up. And you're like, oh, what have I done to you? And actually, I stopped using Depo a long time ago because it's got some really ugly side effects because of this really high progesterone level in Depo-Provera. The other thing is that Provera itself tends to be one of the progestins that tends to cause more weight gain. Unfortunately, Provera is used in a lot of HRT, non-bioidentical HRT. So Prempro is sort of a typical older HRT medicine where they combine estrogen and progesterone in a pill. Both of those are synthetic estrogens. So it was Provera, which is the same progestin that's in the Depo-Provera, and Premarin, which they get from horse urine. Premarin actually stands for pregnant mare urine. So, not the same hormones that the body produces. And weight gain with that is a real side effect. With bioidentical hormones, particularly with the micronized progesterone that we use, it's much less of a problem. Plus, in the dosage used in hormone replacement therapy rather than in birth control, it really shouldn't stimulate appetite and shouldn't have that mechanism to gain weight. But I think that's probably where, at least one of the sort of where hormone replacement therapy gets this bad rap as causing weight gain. Estrogen can cause some bloating, particularly early on. And so that's not uncommon for women, even with the bioidentical estrogen that we prescribe, to get some bloating and some water weight, some water retention that can happen in the first 2 to 4 weeks, the first month or so. And then that slowly goes away. You can help that by drinking more water, and decreasing sodium intake will help with the bloating. But that tends to equilibrate as the body gets used to the hormones, and the bloating tends to go away and the water weight with it. So there is sometimes some initial weight gain, but that tends to go away with time. The other part is that menopause itself can cause weight gain. And so we know that the metabolic effects change with decreasing hormones, and in replacing the hormones back to normal physiologic levels help fix those metabolic changes. So people say, calories in, calories out, which sounds great, except the calories out is really complicated because it really has to do with the metabolic rate and also has to do with where the fat gets stored. So in a younger woman with normal sort of youthful hormone levels, the fat tends not to get stored in the midsection, and you get more of sort of an hourglass figure. As you go through menopause, that fat deposition changes and it more goes to the midsection, and the body shape tends to change, which tends to be something that people don't like. Hormone replacement therapy helps fix those metabolic changes, helps increase your metabolic rate. You burn more calories, but probably more importantly, it gets rid of that fat deposition or decreases that fat deposition in the midsection and gets it back out to where, a more youthful distribution. And so you look younger and feel younger. went on a rabbit trail, and I'm not sure if I answered your question. Did your weight gain, is it caused from your HRT? Probably not. It depends on what's in the, however you pronounce it, the Trush or the Trosh, I'm not sure. It depends on what hormones you were taking and what dosage, but it may be also a function of just the metabolic changes with menopause that can be helped with hormone replacement therapy, in particular with testosterone via DHEA or hardware else. Hope that answers that. I kind of went down a bit of a rabbit trail.
I think you did great.
Okay.
Lorena asks, I had a hysterectomy at age 32, ovaries still intact. I have a difficult time sleeping and losing weight. I'm age 57 now.
So honestly, at age 57, the feelings you're experiencing are probably the same whether you had a hysterectomy or not. The fact that you've had a hysterectomy gives us a little bit more options on treatment, meaning that we can do estrogen alone, or we can do estrogen with progesterone, plus or minus DHEA. The fact that you've had a hysterectomy is important for coming up with a treatment, but it's probably not what's giving you your present symptoms. It's probably more a function that those ovaries that you had aren't functioning as well anymore. And so they're not making the hormone that they once did, and coming along and adding and supporting them with hormone replacement therapy should help those symptoms. It's interesting. Theoretically, hysterectomy should not speed up menopause because the blood supply to the ovaries is different than the blood supply to the uterus. It's the reason that we can take a uterus out and leave the ovaries behind, because the blood supply comes from a different source. So when we do a hysterectomy, if we decide to take the ovaries, we put the clamp in a totally different spot because we have to cut off the blood supply to the ovaries before we cut them. Whereas the clamp goes in a different place, and it doesn't involve blood vessels. There's a little connection between the ovary and the uterus, and there is some blood vessels there, but they're not the major blood vessels. So the sort of standard teaching, and in theory, a hysterectomy shouldn't, without having your ovaries removed, should not hasten menopause. But that doesn't seem to be what we see in practice, and a lot of women suffer menopausal symptoms earlier if they've had a hysterectomy. And I think that there is some decrease in blood flow to the ovaries because there is, again, some blood vessels between the ovaries and the uterus. And I think just sort of messing around with the pelvic structure can somewhat damage the ovaries, and people do lose some function in the ovaries. Doing the surgery myself, it makes sense. It's not the right answer on the test, and if I was recertifying for my board, it's not what I'd put down. But in practice, I have seen that. But honestly, at 57, you've gotten a lot of life out of your ovaries, so we can't really blame the hysterectomy on that. But still, it's sort of that time of life where adding back some hormone might help make you feel better.
Okay. Keita asks, is HRT a risk if you've had multiple women closely related with breast cancer? Mom and grandma all were on hormones. Do you recommend the gene test for the risk?
So my feeling is if your mom had breast cancer, forget about HRT for a minute. Yeah, you should get the gene therapy. It's not the right answer on the test necessarily. I don't think my wife will mind me tattling, or not tattling, but saying my mother-in-law, her mom had breast cancer, and I wanted them to do the test on my mother-in-law because if she was positive, then my wife needed the test. And the doctor fought about it, and basically, because her son-in-law was an OBGYN, she was able to get the test. Fortunately, it was negative. But I think, yeah, if you've got that many relatives with breast cancer, get the test done. Forget the HRT thing, because if it's positive, there's things that we can do to help you so that you don't get that breast cancer that your family members got. I think it's really important. And apart from money, what does the test cost you? There's no risk to it. It's a blood test. You know what I mean? So to me, it's like, this is something that potentially can really make a difference in your life. There isn't risk to it, but I think it's worth doing. So without the whole HRT thing, if you've got that strong of a family history of breast cancer, I think you should get the gene test. And then if it's negative, number one, you can say, I don't have to worry about it. And if it's positive, then you can do really kind of positive, proactive things so that you don't develop that breast cancer down the line. So I think it's worth getting the test. As far as HRT goes, as I said before, just the family history alone doesn't keep you from using hormone replacement therapy. And the whole thing about if you have a genetic predisposition to breast cancer, if one of those gene tests come back positive, it's still a little bit controversial. I personally, again, because I'm so risk averse, don't feel comfortable prescribing hormone replacement therapy. I think your risk of breast cancer is too great. And I don't want to be responsible or even perceived in my mind or your mind as being responsible. So I wouldn't do it. But I think, that may be a controversial position. But again, getting the gene test, just from a basic life standpoint, I think it's really worthwhile. I would encourage it.
Okay. That was actually our last question. You got a bunch of thank yous and a bunch of praise in the chat. I did want to just take a minute at the end to let all of the participants know that we do have a Winona Women's Facebook group that everyone is invited to join, whether you're a patient or not. I'll be adding in the link now, and I hope to see y'all all there very soon. Dr. Green sometimes answers questions on there. I often participate, and so I'm very happy.
Can I say something about that before we sign off real quick? Sorry, I was going to mention this at the beginning and I forgot. I got too into the whole birth control versus HRT thing. That's a really good thing. And, there's perspective that you guys can give each other that me or the other doctors can't give you, because you're living it and you're in the midst of it, and you can really help each other. And honestly, it's therapeutic to talk about this together and help each other out. And it's a good thing to do. So I would join that and be active in it. I think this peer-to-peer, you guys are all going through a similar thing. It's really beneficial to get on there and help each other talk about it, talk things out, and you have a shared experience that's worth sharing. So anyway, sorry, that's my pitch.
All right, I think we're probably going to close out now. Thank you for everyone for coming.
Thanks, you guys. See you next month. I'll see you on the dashboard.